Now it has been touted as the vehicle that will finally deliver universal health coverage to all Kenyans. But months into the transition from the defunct NHIF, the Social Health Authority SHA is facing a storm of implementation gaps and funding shortfalls. Today, the Institute of Economic Affairs, IEA Kenya, released a scathing assessment of the scheme's progress, highlighting chronic underfunding as one of the key challenges facing the authority. Brenda Wanga reports.
1.5 years into the implementation of the government's universal health coverage operated through the 3 SHA funds, and this ambitious undertaking continues to run into headwinds, the biggest one remaining financial. As at the end of last year, the primary health care, the emergency chronic and critical illness, and the social health insurance funds remained underfunded to the collective tune of 116.1 billion shillings.
The funds that are generated are not sufficient to run SHIF. And then, of course, the other one is their weakness. The means testing tool actually undermines sufficiency of funds. So there are weaknesses to that tool, and I alluded to that. No doubt, if the resources that are generated are not sufficient, then that raises the risk of financial sustainability, which obviously leads to delays in payments to facilities, and this ultimately undermines service delivery.
Beyond the cash crunch, the report reveals that while millions have registered for SHA, the contributions to the fund are not commensurate with the numbers. The authority is also grappling with what it says is the reluctance by the public to seek medical help from lower-level facilities covered under the primary health care fund, and instead are overburdening facilities covered by SHIF.
Actually, what that means is that it ends up inflating claims for SHIF, but also this affects detection of chronic diseases. And it means the payouts from SHIF and DCCIF tend to increase because patients are actually bypassing primary health care to go to these facilities.
Implementation realities on the ground are even more stark. Many hospitals are reportedly opting out or demanding co-payments because SHA tariffs often do not cover the real cost of medication, consumables, or specialist fees. Health facilities, on the other hand, are still finding their way around the digital operating systems of SHA, which further compounds the challenges plaguing SHA.
The benefits package is quite ambitious and expensive. There's a huge crisis with claims and reimbursement impacting on facilities and service delivery, and we still have operational and capacity gaps, so suboptimal digital connectivity. So even as much as SHA has actually enhance its systems, we still have what is called, digital connectivity facilities.
To save the scheme from collapse, the IEA is proposing a series of radical shifts, including the rationalizations of the benefits package to align with the actual financial resources available, the smart enforcement of the means testing to include data integrated and human verifiable approach to improve accuracy, exploring innovative funding to boost PHC and ECCIF funds, as well as deliberate methods to clear the existing debt from the now defunct NHIF. The authority has also been challenged to improve its systems of reporting and monitoring to stem what is now emerging as avenues for fraud, including claiming for more expensive procedures than those performed, falsification of records, conversion of outpatient to inpatient bills to claim more money, and multiple billing and ghost patients. Brenda Wanga, Citizen TV.